So I'm Paul Connell from ODI Leeds. We've got some new faces on the session. In 2020, we had 20 sessions, 100 speakers, and over 1,000 people joining us on these Open Data Saves Lives work, which were very broad in their subject matter, but they covered all the things linked to data and health, and particularly COVID-19. And today we're really happy to welcome Jess Morley and Chris Bates, who on different aspects have been working on the OpenSAFELY project, which we've been watching from afar with and applauding for some fantastic work that's been going on there. So Jess is going to be up first, telling us about the work they've done, and then Chris is going to talk through how he and other partners, so TPP and EMIS and other partners, have built rapidly, I think in record time, the infrastructure to feed the OpenSAFELY project, which is again is amazing, and just shows you what can be done when people need to do it. And then we're going to finish off with Stuart Lowe from ODI Leeds, who works on data projects and has created a fantastic stacked plot of data. And you might recognize the visualization, but I'll let Stuart, I don't want to steal Stuart's thunder here, but Stuart will talk us through that. So we've got a little bit of a lighter finish to the session. So as we always say, we're going to start at 11:03, which is great these days. People turn up on time for video meetings these days, don't they? And it's quite interesting, the death of distance. So we're going to wait until 11:03. Then I'll introduce Jess, then Chris. If you please jump in the chat if you want to mention anything, if you want to talk to people, if you want to share contacts, please do that in the chat. I'm sure Jess and Chris will be sharing links on the work that they've been doing as we go. If you've got any specific questions, please pick them up. Mark, if you can look at the chat, and if there's any questions I miss, please let me know. And then we always say this: if you could share what we're doing, we'll put the OpenDataSavesLives.org website in the chat as well, so people can see there. Next time, I'm hoping that we can share with you some good news about what we're going to be doing as we come up to our first birthday, which is amazing. So hopefully we're going to have some really good news about what the next phase of Open Data Saves Lives is all going to be after our first birthday, which would be very welcome. So it's 11:04. What I'd like to do now is welcome Jess Morley. Jess, you can just introduce yourself and the team, what you're doing. And I'm really looking forward to this, about understanding a little bit more about the OpenSAFELY project. Over to you, Jess.
Great. Thanks so much for having me. Hello, everyone. I'm Jess. I am the policy lead in the University of Oxford's DataLab, which is headed up by Dr. Ben Goldacre. That's half my time. The rest of my time, I, in theory, do my PhD, although I don't spend an awful amount of time doing that because we do fun things in the data lab and I get distracted. So today I'm going to talk a little bit about OpenSAFELY. You can see the website if people have not seen it. It's literally OpenSAFELY as one word.org. And it is a highly secure open source software platform for analysis of electronic health records, where all the code for data management and analysis is shared openly by default for scientific review and efficient reuse. We built it in response, if I say we, I'm massively taking credit for the incredibly talented software engineers in the DataLab team and from TPP and EMIS, as Chris will talk about later, but we built it in response to the COVID-19 pandemic in order to enable secure access to large volumes of patient records to do studies on things like factors associated with COVID-19 death, who was most at risk, to also look at effectiveness of different types of treatments, to look at interactions, for example, with multi-morbidities, all these types of urgent burning questions that the system was desperate for at the time. And we went from idea to first analysis in 5 weeks. And we now have the capability to run across the records of about 95% of the country, but we don't do that all the time. Chris will, I'm sure, talk about that. But our main aim with OpenSAFELY was to provide a mechanism for analysing data that goes above and beyond the current legal and ethical requirements on securing sensitive healthcare data. So the main thing is OpenSAFELY does not move the patient data outside of the secure environment in which it is already held for business as usual. Instead, trusted analysts can run large-scale computation across near real-time pseudonymized patient records in situ. So the data stays where it is, we send the code to the data. OpenSAFELY does not therefore give you unconstrained access to raw data on a raw machine. So we do not allow large data downloads in the way has been traditionally been allowed. And it allows a lot of additional benefits because of this security. It means that we can access larger volumes of data than would have previously been possible, which means you can do analyses with more statistical power, for example. And there are a few other things that are a bit unique about OpenSAFELY. So OpenSAFELY logs every single thing that is requested of the platform. So whenever there is a query sent to the platform, it is automatically logged. All code has to be a default be written in public domain in the GitHub repository, which means there is effectively a full audit log of any query that has ever been sent to the platform, which is not really something that you can normally do. You can't normally go and say what analysis has been done on my patient data on my record. We have that entirely logged. Thanks, Paul. Which is just a very powerful way of improving transparency and being provably trustworthy. So in addition to the fact that we don't move the data, everything happens in public domain by default. And what analysts get back is normally aggregate statistical data. And there are a number of checks along the way as well for additional security, for example, small number suppression. And the reason why everything is open sourced and shared under public licenses is because we believe this is the benefit for public health. And we want to enable many people to be able to do analytics. We want to produce and encourage the development of an open ecosystem of people analysing healthcare data. And we want to enable people to review and reuse the code that we have made available. And therefore, OpenSAFELY is a highly collaborative process. So anyone who uses OpenSAFELY is expected to be able to contribute to the development and expansion of the platform. For example, by contributing to code lists. So I will try and share our code lists, which in the chat, if I find my chat, so you can see. There's the chat. So all of the code lists that are developed for OpenSAFELY and by the OpenSAFELY team are available there for others to reuse them. And we are aware that it's quite difficult sometimes for people to get credit for this type of thing. So this is the other thing we're trying to work through, is look at how do we give credit for software development? How do we give credit for the bits and pieces that go behind producing analysis rather than just the final publication? And so that's why we also have this reason why we make the code lists available for public, and you can see who developed it, and it makes it easier to track. And our hope is that we will be able to do things like put DOIs on the code lists and enable people to cite them. And we have a blog about this actually on the DataLab website. And we are working currently, the main people who use OpenSAFELY are researchers in Oxford DataLab and researchers in the London School of Hygiene and Tropical Medicine, who are our partners in developing the whole of this platform. But we are working towards a goal where we have other researchers using the platform. And we are piloting this process as an onboarding process at the moment to look at how we do that. There's currently a two-step process of application. You are reviewed by IG, by NHS England, who are the ultimate data controller, and we as a DataLab team are reviewing for feasibility and technical capability. And So those are really our main principles. So it's a big analytics, secure analytics platform. It enables remote access to large volumes of patient data by safe analysts. The data doesn't move. Everything is logged in public by default. You have to work in public by default in order to encourage people to reuse and share and review their code. We don't consider the only outputs to be the final analytics paper. We're also encouraging people to contribute to the software development platform, and that's something that we think is quite unique. And then we aim to be provably trustworthy, rather than just assume that because we are a trustworthy organization, people will trust us to use their data. We're trying to be demonstrably transparent about it and to develop everything in the open and no domain. So those are the basic principles of how we work, and I can already see there are some questions in the chat, so I will try and answer them before we pass over to Chris, who's going to talk about the technical side, but also specifically talk about our recent work on vaccine effectiveness and uptake, which is super exciting. Mark, what do you think this all means for the role of NHS Digital? I don't know what DSCROs are.
They're the DISCROs, some of the commissioning support units that are set up to be able to handle identifiable data and be the kind of escrow function, if you like, where they can take clear data in, pseudonymize it, stand it up, and then pass it out to the NHS, back down to the NHS, to people like me. So big CSUs like NEX in the Northeast and South Central West, they're a function set up by NHS Digital to create a means of linking primary care data, secondary care data, and so on.
Sure.
And they're the normal way of linking this. So that's why it's really interesting what you're doing.
So I don't think the fact that OpenSAFELY exists at the moment, for one thing, OpenSAFELY is an entirely portable software platform. So it could be used by anyone to access any data set. So there's no reason, for example, why NHS Digital could not use the way that OpenSAFELY is designed in order to enable access to the data set that it controls. And similarly with those other access mechanisms. I should also say that currently we run against the TPP and the EMIS databases under the basis of the COPI notices. That might change in the future as well. And so we might move to OpenSAFELY for different reasons. And this is one of the main reasons why we were very committed to OpenSAFELY being open source, modular and portable to enable this exact type of flexibility. Does that answer the question?
Yeah, it's helpful. Thank you.
Did I say NHS England are the data controllers? Yes, NHS England are the data controllers. So anything to do with decisions around what the data we currently using, so the TPP and the EMIS data, what we currently use it for in terms of the types of questions that we ask of the platform, that is agreed by NHS England, partly because of this connection with the COPI notice.
Thank you.
Can we be implemented over other large clinics? Yes, so that's the same question basically. To Daryl, yeah, we can. You can use it to run against anything. It's not entirely trivial. There is like some integration that would need to happen with the back end of that particular data repository that you were talking about. But yes, the theory would work the same. Yeah. Do you have any other questions right now, or shall I pass over to Chris?
Well, I'm gonna jump in and just say thanks very much, Jess, for joining us. And if anyone's got any questions about OpenSAFELY, how would they do they just find you on Twitter and send it to you there, or is there a more formal way of doing it?
But it's absolutely fine to ask us on Twitter, either me directly, so I'm Jess R. Morley, or OpenSAFELY on Twitter, which is also me anyway, but it's or you can go on the website and there's an email address, which will email the whole team that you can see, and we can answer that way. And I would also say we have some exciting engagement stuff coming up. So we've commissioned an animated video to be made to explain how the platform works. And so any questions that you do ask about the platform and the way it works is very helpful, because it helps us inform this. And I know lots of people on this on this particular call are also quite technical. So the full documentation for OpenSafely is available there, which anyone can read, as well as looking at the code on GitHub. Bearing in mind, everything is always a work in progress, and we're always looking to improve.
Fantastic. So thanks very much, Jess. If there's any other questions, just put them in the chat. I think, Jess, you can stay for a little bit.
I'll be here.
Yeah, and what we're now going to hear is Chris Bates is going to go through some of the vaccines data, which I think this is almost hot off the press, isn't it?
Yes, and there's a hot off the press that's not quite got off the press that I'll hint at the end.
Fantastic. So, Chris, if you just let us know who you are, where do you work, and also how you've been working on this, that would be amazing. And then tell us what's going on.
Sure. Morning, guys. Thanks for having me. So yeah, my name's Chris Bates. I am Director of Research and Analytics at TPP. TPP, we're an electronic health records provider, clinical information systems provider. So we supply systems to general practice and hospitals and mental health settings, for example. And we supply that to about 50 million. We have records for about 50 million people across all those settings in the UK. So we've always run a big central database, on behalf of NHS colleagues that hold these electronic health records for people. And as Jess has said, about a year ago now, we had the first conversations with Ben Goldacre about some other research as it happened, but we turned quickly onto this. And we were able to work very collaboratively together with small teams on behalf of NHSE to build this platform. And what that means is that we have this big research database which sits inside the central infrastructure we have inside secure NHS accredited data centres. And then Ben and the team and the epidemiologists at other research institutions can effectively dial in the secure way that Jess has pointed to, and there's lots more information on the website, to be able to run those analyses, retaining the power of being able to work on really big data and really high dimensional rich data, but without compromising, confidentiality in probably the most tightly regulated data sets imaginable. What I want to do today is to show you what the sort of consequences of the model we've built and the data sets that we've built are for rapid analysis for COVID-19. And as Paul said, I'm going to talk about vaccinations. Vaccination flow is kind of complex and kind of been a work in progress around the NHS. For any of you that are involved, I'm sure you know this, but ultimately, wherever a COVID vaccination is recorded, whether that's at Ellen Road, whether that's in a hospital, at your GP practice down the road, in a care home, it makes its way back onto your GP record. And that's the context of what we're talking about, because once that vaccination's on your GP record, it means it flows into the OpenSAFELY database, so we can start to do some interesting analysis. I'm just going to share my screen with you. Can people see that? Wave if you can.
Yes.
Great. Fantastic. So this is some analysis that came out very quickly. And this, the vaccination program starts kind of mid-December, and the vaccination flows start around that time into general practice. And then by early January, what we've got is we've started to get good information in the system to be able to do, some really interesting analyses. And what I want to talk about really is how those analyses in the context of the rest of the medical record have mean we can do some more interesting things, and to really be able to track what's going on, to try and influence policy, and to really shine a light on what's happening. So this was picked up by The Guardian very early on, and you can see the discrepancies in the cohort there in terms of ethnicity. So this was looking at all the over 80 plus age group, the first cohort who were getting vaccinated, breaking it down by white, British, South Asian and black. And so you can see there we've got more than 80% of the white population had been immunised by the 27th of January, and you can almost halve that. And we could only do that because we've got that information in the system, but we've also got ethnicity data as recorded by the GPs. What is kind of cool about this, from our point of view, and from the audience today, is this is a link in The Guardian, and normally you might see a hyperlink there to a research paper, and it might be some a preprint or some published paper. But the link here is a link to the GitHub repo that Jess was talking about. So in that repository is all the analytic code that's gone behind this, the papers there, all the graphs, every bit of information you could want to be able to effectively see what we've been up to is available to people who technically want to get under the hood of what's going on with the data and want to analyse what code's been running. So it's as open as you can possibly be. I think that's great. If you follow that link and you do that now, you'll start to see the sort of things we've been able to do. And to start with, these are kind of similar to things you could do from other data, just from the central data sources of who's been vaccinated. So we can see, this is last week's report or the week before, so you can see how many people have been vaccinated, how many in the 80 plus cohort, how many in the 70-90 cohort, and that's kind of stuff you can get from national statistics anyway. We start to be able to get a little bit cleverer in terms of how many people have been vaccinated within the care home population. It's actually a tricky question from address data to say who's living in a care home, and people who've been involved in UPRN and geographic data sets on the joining us today will be well aware of that. And then we can sort of start to see more of a breakdown, who's had the AstraZeneca vaccine. So really just some simple descriptive statistics, which are very useful, but in the context of OpenSAFELY, not really utilising the whole power. Where we wanted to use the power was, as Jess alluded to, our first big publication, this was in Nature last July, was to look at the descriptive factors associated with COVID-19 death, because these have very much informed vaccination policy in the UK as to who we should be, this kind of work and lots of other work alongside it. So you can see here, as we all know, age is a huge factor. The red line there is a kind of hazard ratio of 1. Age, as you start to get older, becomes a really dominating factor for poor COVID outcomes. It was the same with ethnicity. If you come down there, the same with social deprivation. The more deprived you are, the more likely you were to have poor outcomes. And then into some, physical and mental health conditions. So at the bottom there, this isn't the whole list. We've got some cancer data showing that if you have recently suffered with cancer, you are more at risk. Alongside that, as I've said, there's been lots of other work. The Joint Committee of Vaccinations and Immunisations, I'm sure most people are aware, have got lists of conditions of people now who we want to prioritise for vaccines, because lots of studies have been done, including that OpenSAFELY work, who've really shone a light on who's most at risk. There's a JCVI list, but also other government things that we do know from publications from Public Health England and from UK Biobank, which some of you will be familiar with, in terms of pre-existing mental health conditions and the impact that has on poor outcomes for COVID, and people living with learning disabilities and the poor outcomes there. So all of this is fed into the cohorts we're trying to vaccinate as early as possible to give maximum protection we can in the country with the vaccinations we have. From an OpenSAFELY perspective, we can then start to break down those cohorts. And again, this is all available on the GitHub repo. So if we're looking now at the 70 to 79 population, this is a population we're starting to finish, we can start to do those breakdowns. So on the left there is by ethnicity. It's kind of the graph I've already shown, but you can see, this is very, very recent. The Guardian article was January, and we haven't really changed that situation. We've still got that discrepancy there. It's multifaceted reasons for it, but it needs tackling. If you look to the right, that's about deprivation. And you can see that in this kind of univariable analysis, deprivation, it's still there, and we can see that trend. The least deprived people are more likely to be vaccinated, but it's not quite as stark as on the right. If we move to those clinical conditions, it's pretty good actually. So, as I've said, cancer is a risk factor for poor outcomes. Recent cancer diagnosis is a risk factor for poor outcomes from COVID, but actually the yes and no's in that binary situation have both been vaccinated at a very similar rate and a very high rate. The same for dialysis patients. People living with kidney problems, again, were at risk. However, if we move to the other two I mentioned from PHE and from Biobank, if we look at intellectual disability and we look at psychosis, schizophrenia, and people living with bipolar conditions, you can see the discrepancy there. So we're able to use that data, this data set, to be able to say we do have to do some work nationally to close that gap between people living with intellectual disabilities and people living without them in terms of the vaccination rates. And how do we go about doing that? And I think that's really important for us. And what we're trying to achieve with OpenSAFELY, and as Jess says, it's for the good of public health. We've been able to do this quickly and to highlight, from the data, real problems that need tackling now. We can't wait, 3, 4, 5 months before we get on top of these. So it's showcasing what's possible with good quality data. As Jess said, what we're really keen is that everyone can see exactly what we're doing. A lot of that analysis historically on healthcare data has taken place in the dark. So if you go to that repo, you can read how we construct study definitions and what the code looks like. And you can effectively read this in English. This is how we're defining who has had a COVID vaccination for the AstraZeneca vac for that cohort. And you can follow that code through, and that's exactly what it is, and that's what the analysis is running. At the same time, how have we defined how someone's living with psychosis, schizophrenia or bipolar conditions? Again, in healthcare, and maybe won't be in healthcare, as much as possible, there are codes dropped onto patient records, so machine readable codes, so that we can start to analyse those things with the machine, and we can actually do some analysis rather than just having text. But people in different areas often put different code lists together to mean, what do I mean by psychosis? Because these terminologies are very, very broad, and often that's not public. So again, Jess has posted a link to code list. We've tried to make that really transparent so people can see exactly what we're doing and exactly how we're defining that condition. So upcoming results, what's next? I mean, if you ever want to see what's next, and I don't know if I can just switch screens, Jess alluded to the fact that we are trying to make this as transparent as possible. So this is live, this is real time at jobs.opensafely.org. And you can see at the bottom there under the latest jobs, there's a small blue circle twiddling away. And that's because what's running now, the job that's running is about hospital disruption. So a piece of work, you can see exactly what analysis is running. And if you click on view and follow it through, you can see the GitHub repo. So you can see as transparently as possible the kind of work that the researchers are doing on this data set in real time to enable you to do that. So, you know, you can check that out and see what we're up to. In terms of vaccinations, what we're doing, well, the most interesting analysis that's about to come out is really around variants of concern. So we work very closely with Public Health England and NHS England to try and get the data as it's coming in, you know, more data that we can link to this to enable the guys at DataLab and at London School of Hygiene and Tropical Medicine to do this kind of work. So we've now got variant of concern data, so we're able to look at things like case fatality rate and transmission rates. And as new variants emerge, you know, this is going to be a way of being able to do that rapid response. But rather than it being quite, you know, a blunt way of doing that, as I say, we've got that rich EHR data. We can start to do breakdowns by different clinical conditions, different mental health conditions, and different demographic factors to try and get a better handle on what's going on and try and inform policy. As Jess said, everything's at OpenSAFELY.org, and the GitHub repos, most of them are public. They become public as soon as we can make them that way. If you want to ask Jess anything, it's at OpenSAFELY. If you want to ask me anything, I'm Dr. Chris Bates on Twitter, and please, yeah, fire us with questions. I don't know if there are any questions. Sorry, I'm losing that. I'll just stop sharing. Cool. So yeah, so if you've got any questions, please ask away. Hopefully that's given you an indication of what we're up to in vaccination space.
Thanks. And well, there's a broader conversation around demographics and how we create categories, and whether they need to be more granular, and so that we can actually see where the problems are and what there are. Because it seems, I mean, Mark's made the point that maybe the categories we've got at the moment are too broad, or not quite the tool for the job. And maybe there's a bit more work to do on that.
I think they are the kind of slightly different. I think deprivation is not too bad, to be honest.
Yeah.
From a healthcare point of view, the problem we have, we're using the indices of multiple deprivation. They're not perfect, but you have kind of you have 32,000 different categories. You know, so there is a granularity there. The problem is when you're trying to do some analysis we've done, for example, with COVID-19 deaths. If you start to go down to the level of granularity of you know, 1 in 32,000, the numbers become too small. You can't really do any analysis that shows anything meaningful. So we unfortunately still have to do some more cruder deprivation work. Ethnicity, I think, is an absolute a massively important point, Mark. I completely agree. There is a programme of work NHSE are doing at the moment where they've taken ethnicity data from general practice and ethnicity data from the hospital episode statistics, and they're combining those together to try and get a richer ethnicity data set to then refine what's recorded in general practice. However, I don't think that'll quite solve the standardization of collection, and I think we need new ways of doing that. One of those ways, hopefully, is as people engage more with their own electronic health records through smartphone apps, the NHS app, the app we provide, etc., and can start to contribute, that they should be able to, you know, self-declare their ethnicity in that route as much as possible, whilst avoiding digital bias. Jess will tell me off. You know, I think we've now seen in the middle of a pandemic how important that information is. So there needs to be a good strategic national approach to having better data quality there, definitely.
Yeah. Definitely. I think that's something that Open Data Says Large is definitely going to be looking at over the next year, is how we can help in that process and try and get to a work at pace, but not make some mistakes. So I think it's definitely taken on the OpenSAFELY approach. But also, I think there's also that this isn't anything new, and there's a whole load of stuff that already exists which we could apply. And I think that might be one of our other jobs as well, is to show people what already exists and say, please don't spend another 6 months on a discovery program when a lot of this stuff already exists in one place, and we might be able to springboard and amplify that work together. So that's definitely something we can come up with, and share. And if you've seen the Richard Webber Origins database, which is based on surnames and not on self-declared groups, because obviously, one day you might feel one thing, one day you might feel another, and then you might declare yourself and tick a box because you think it might help you in the future, or to be thought that way. So I think there's a bunch of stuff we can do on ethnography and other data sets which help us get some much more granular information, which protects privacy and protects people's data rights as well. So really looking forward to getting stuck into that. Okay. Yeah, Mark's good. The great example of British Turkish Cypriots and Nigerians in London. That they don't self-declare on how the stats people would like them to be in terms of health categories, because they don't recognise them as anything real. So yeah, that's really important. Great stuff. Okay. If there's no more questions, or if anyone's got any other questions or would like to raise their hand now, what we're going to do now is we've got Stuart Lowe, who works on data projects here at ODI Leeds, has created a stacked line plot of the COVID data, and you'll probably recognise the album cover when he shares his screen. But as an astronomer, he doesn't recognise it as an album cover. It's a pulsar.
Yeah. Okay, so let me share my screen. I'll start with some context. So hopefully people can see the screen. Can you hear me as well? Yeah. Right. So that's the PHE coronavirus dashboard showing you cases for the UK. You can also drill down to a specific local authority. For a while now, we've had our local authority dashboard, which takes the data from Public Health England, and you can customize this dashboard to the set of local authorities you want. At the moment, I'm showing here West Yorkshire, but if you scroll to the bottom of the page, there's a big yellow link here to customize it to whichever local authorities you like. And we've got a combination of the Public Health England cases data, confirmed cases, and ONS, the weekly ONS death data down there as well. But looking at all of these graphs at the top here, the confirmed cases, I start, as there's been a year's Astronomy, which was this plot here, which gave you the Joy Division album cover. And it was basically pulses from a pulsating neutron star. You don't need to know the astronomical details, but it's basically a series of pulses stacked vertically. So there are disadvantages to this type of plot in that you get things hidden by features in the landscape, as it were, but there are some advantages as well. So I started off by just plotting every local authority's cases. So left is around the end of February last year, and the right hand side is now. And this shows you the number of cases by local authority. This is ordered by ONS code number, which isn't particularly useful for anything else. So if I can get rid of the, if I can see the top of my screen, unfortunately the Zoom controls have now appeared and I can't switch tabs, which isn't exciting. Let me try doing it this way. I'm just gonna have to make my window slightly smaller so that I can actually see what I'm doing here. Right, hopefully you can still see. So this is now ordered by how northerly the centroid of the local authority is. So basically if I put my mouse over down here at the bottom, that's South Hams, and you've got Plymouth down there and Torbay, and then up at the top here you've got the Shetland Islands. Scotland starts somewhere right up here, just because local authorities, people tend to forget how many local authorities are in England, so Scotland starts very near the top, and Wales is mixed in down here. South Wales is mixed in down here. But let me go through some features that you can see once you plot all the local authorities. So first of all, the first peak, which is over on this side, obviously we were not doing very well on testing at that point, so we don't really see the first peak there. Testing started to improve somewhere, hopefully you can see where my cursor is, somewhere around here. There are some individual things like Merthyr Tydfil, Wrexham and the Isle of Anglesey, which were meat plant outbreaks. You can see those as little tiny hills in the data. This feature here is Northampton, which had a sandwich factory outbreak around August. So that's that little bump. Leicester had sort of ongoing issues and talks of local lockdowns. So you can see Leicester sticking out in the landscape. And there's a few other places like Oldham and Blackburn and Pendle, which stand out a little bit. Also tiny little bits in Burnley, but as you can see, the different sizes of features. And by this point here, we were probably doing very well on testing, so we're probably catching all the cases. And then the other thing I want to bring attention to really is the fact that the north and the south have, if you ignore South Wales, which are some of these little bits in here, in England particularly, the north and the south have different pictures for a second and third wave. The north has this hill here, this mountain range, which is the second wave, and then a sort of flattish valley, apart from Lincoln and Boston, which are standouts there. And then it has a very distinct third peak there, whereas once we get to Milton Keynes, roughly, and south of Milton Keynes, you can see that the south didn't have much of a second mountain range, apart from, as I say, bits of South Wales and Bristol, which are these areas here. But in the southeast particularly, their second wave, or which is I'm going to call the third wave, started coincident with the end of the second wave in the north, more or less. And you can also see some little features, dips here, which are basically these little dips in this peak are Christmas, which might be down to reduced testing over Christmas. It might be down to the fact that restrictions came in the southeast about the 19th of December, I think it was, so that would have started to reduce cases as well. And then Christmas might have started to increase cases as people were visiting each other for Christmas. So you can then see after the third peak, Rutland's had some outbreaks, and then up here in East Ayrshire has had something else. So as I said, there are disadvantages to this type of plot because it hides some features. I've tried to make them semi-transparent, and you can hover over individual local authorities and it might make it a little bit clearer where they go. Obviously, we've still got our main dashboard if you want to see that specific local authority, but just to get a trend, a local trend on a national scale, and split it down by geography, this was just an interesting way to do it. Now, I'll just, having shown you that, I'll just go on a little bit on the vaccine data just to show. So NHS England publish vaccine data with breakdowns weekly, and it'd be interesting from Jess and Chris whether some of their breakdowns, their weekly breakdowns, use OpenSAFELY or not, because they've started to get more detailed about what they show. I'm making maps by NHS Integrated Care, something ICS or STPs. I lose track of all the NHS acronyms, what they exactly stand for, but they're sort of smallish areas of the country covering things like West Yorkshire and Harrogate, although technically Harrogate isn't in West Yorkshire and Harrogate. Harrogate's in Humber and Coast and Vale, and I've made maps of England showing you the fractions of each age group that they publish. You can also get totals as well, but the fractions by first dose and second dose, and then there's a massive table that you can sort by whichever column you like to order things. So there's that. We've also, as of last week, they started publishing by MSOA. So I put all of that onto a big map of the country. It's just for England. It doesn't unfortunately cover Scotland, Wales, or Northern Ireland. But this lets you go in by MSOA and see the fraction of each age group that they publish. So if I do percentages of under 70s, That's percentages of under 70s. Those who know Leeds know this is the area with the largest percentage of under 70s is all Woodley that's been vaccinated so far. But you can change through the different age groups. So if I do hopefully 70 to 74s as a percentage, then it's a part of South Leeds, Dock, Hunslet and Sturton, which is currently doing the best on percentages. Although a word of caution is that the percentages can get quite ridiculous. So here is 130% of 70 to 74-year-olds. And that is most likely because MSOAs in order to work out percentages, you need to divide by the population, and the population is using a 2019 estimate, which it's likely the population is bigger now in 2021. So that will make the percentage greater than 100 if you've done 100% of people. But also it could be that people have moved in the intervening time, and that's not modeled in any way. So it's very likely that if people are in these age groups, they may have moved into other accommodation nearby, but will be in a different MSOA. So they've shifted where they are. So things can be biased by care homes and things like that. So the numbers should be taken with a pinch of salt once they get to 100 or so %. Obviously, there's not 130% of people vaccinated. That doesn't make any sense. But anyway, so we'll put links to that. This is on our data mapper, and I'll update it once a week on a Thursday afternoon when NHS England update theirs. So that's me.
Thanks, Stuart.
Sharing.
We'll put the links in the chat and we'll share them on the Twitters and wherever. But it's a fascinating way of looking at the data, and I think there's going to be lots of that. And finding quick ways to look at what's meaningful in the data is part of what we're constantly looking to do here at ODI Leeds and the Open Data Saves Lives team. So we're 11:42. We've had 3 great talks. Hopefully with lots of people have learned something new and join in. I've just got one thing to say, is that we've got our Northern Lands Conference. It's on the 15th and 16th of March. Ben Goldacre is speaking at that about OpenSAFELY. We've got a bunch of other people talking about health innovation and data, but also not just from England and the North England, but also from the Netherlands. So some aspects from that. So the Northern Lands is North England plus the Netherlands equals Northern Lands. All about data innovation in those 2 places. And it goes without saying, this is a post-Brexit place where the Netherlands want to stay friends with us, and we obviously want to stay friends with them, and we've got more in common than other people might want to say. So this is part of our approach to keeping the contact between people like us on the call who are interested in data. It might be a little bit nerdy, but also know that things are really important. So please have a look at that and sign up. And then Stuart's just put the links to our visualizations in the chat.
Well, can I just, Ulrike asked, is it possible about the second dose? I should also point out that so the MSOA level data is any dose, so it's anyone having any doses, whereas the maps using the NHS, ICS and STP data, it splits it down by first and second dose.
Yeah, fantastic. Okay, but before we go, we're going to be smack on time, 11:45, which is amazing, and we've got 3 great talks. So would anyone like to make any points before we leave, or mention anything? Mark Wood, anyone else? Fantastic. Mark, over to you.
We should remind people that we've got other sessions coming up. So
yes,
between ourselves and the Health Foundation, we've got a rolling programme, and that'll all be on the website and all on Twitter. We did some work around care homes, which I think have been overlooked for too long. So that's going to be a big session. We're going to do something on social care more widely through the Health Foundation. And just a kind of point of reflection for me very quickly, we did a session a month or so ago around the role of the analyst. And I think because we're catching up so quickly with the data through, Chris and Jess, and then visualizations for people like Stuart, I think the people who've actually then got to make a decision, the kind of policy wonks, are slightly on the back foot actually now. And I think we should probably come back to that, because I think where people used to make decisions with not a lot of data, there's now really good data coming. And I think there's a whole management science around how people frame research questions and then actually make decisions based on it. So, you know, some of the stuff that Chris is publishing, what policy changes are actually then made based on the data that Stuart's got, how might they tweak the vaccine programme, you know, almost in real time, I think is really interesting. And I think we should kind of try and reach out into that space beyond the nerdy space into the policy wonk space.
Absolutely. I think that's part of our job is now to create the tools for people. Real-time decision making is really hard or really easy. It's, you know, sometimes it's really easy to make a decision and say, okay, we've got no data, but it's the right thing. But actually, I've got the pointy finger saying, you're wrong, you're still wrong, this is wrong, you need to do something about it. Okay, that means a new institution. So that's really hard for people to do. So yeah, that's a really great point. Jess, you just put the link to the Goldacre review in there. We might pick this up afterwards, but would you like to use Open Data Saves Lives to capture some feedback into the Goldacre review?
Yeah, that would potentially be very good. We're running a whole load of open events, but they're quite oversubscribed. So if the community would be interested in feeding back, then I would be definitely up for helping facilitate that.
Cool. Well, maybe we'll do that and have a word afterwards. If there's some questions that aren't getting picked up, or maybe there's some things falling through the cracks in terms of your events, we can use this ecosystem to do it.
Yeah, that would be fab.
Okay. Thanks everyone. I'm going to make a cup of tea and I'll see you soon.